Chapter 20, Slide 1. In this chapter, you will learn about the knee and the most common conditions relating to this joint. These include ligament sprains, meniscus tears, dislocated patellas, and chronic patellar conditions, including Osgood-Schlatter. You will also understand the basic concepts of knee evaluation. However, there are multiple special tests for the knee, so the emphasis will be on understanding the most common mechanisms of injury and how they injure the knee. Treatment and rehabilitation will also be included. Please use the PowerPoints to guide you in your reading. Once you have completed the readings for chapters 20 and 21, you can prepare your responses to the forms located under Session 5. Slide 2. The medial side of the body is located closest to the middle of the body. So when I refer to medial, think of middle to help you out. The lateral side is on the outside of the body. Begin by exposing one of your knees. Locate the following bones. The femur, referred to as the thigh bone, is the strongest bone in the body. It is the bone that connects the hip to the knee. The tibia was discussed in the previous chapter. This is your shin bone. The tibia connects the knee to the ankle. The fibula is the small bone on the outside of the knee. Gently palpate in this area to locate the head of the fibula. The patella or kneecap is the largest sesamoid bone in the body. The articulation of the patella over the femur and tibia can be considered its own joint. An array of injuries occur in this area. Extend your knee. Place 2 fingers along the length of your medial patella and draw a vertical line. This is where your medial collateral ligament is located, referred to as the MCL. This ligament is long and flat. Now place 2 fingers along the length of the lateral patella and draw a vertical line. This is where your lateral collateral ligament is located, referred to as the LCL. This ligament is short and rope-like. Slide 3. Refer to the diagram on this slide and to your own knee. With your knee flexed, locate the patella. Just below the patella is the patellar tendon. Palpate this. This is the area where athletes get patellar tendinitis, also referred to as jumper's knee. The patellar tendon attaches to the tibia. This is referred to as the tibial tubercle. This is where adolescents sometimes experience the painful condition referred to as Osgood-Schlatter. With both index fingers on the patellar tendon, move about 1 inch laterally and the other 1 inch medially. You will feel a spongy, squishy bursa. The bursas are the WD-40 in the knee and act as the lubricant. If you continue moving your finger both laterally and medially, you will feel the joint line where the tibia comes into close proximity with the femur on the medial side and where the fibula comes into close proximity with the femur on the lateral side. It will feel like a groove or small canyon. This is where the medial and lateral meniscus are located. Refer to the next slide for more information. Slide 4. Here is another view of the anatomy of the knee. You are looking at it straight on, and the patella is lifted up so that you can see the inside of the knee. Notice the ACL and PCL ligaments that cross in the middle. The ACL ligament is in the front, and its job is to hold the tibia stable and keeping it from slipping anteriorly. The PCL ligament is located in the back, and its job is to keep the tibia from slipping posteriorly. These ligaments cannot be palpated directly, like the MCL and LCL. The blood supply of the ACL is very rich, which means when this ligament tears, there is immediate swelling. This ligament is also attached under great tension, so when it tears, the athlete will often state that he or she heard or felt a pop. I remember hearing an ACL tear from the sidelines during a soccer game. The LCL is often referred to as the fibular collateral ligament, and the MCL is often referred to as the tibial collateral ligament. Locate these ligaments on the slide. The mechanism of injury for ACL tears include hyperextension, rotation, and also a valgus force, which means the athlete gets hit from the outside of the knee, buckling the inside of the knee. The mechanism of injury for PCL tears includes hyperflexion primarily. The mechanism of injury for MCL tears is a valgus force. Again, the athlete gets hit from the outside of the knee, which buckles or stretches the medial ligament. The mechanism of injury for lateral collateral ligament tears is a varus force, when the athlete gets hit in the inside of the knee, causing the ligaments on the outside to buckle and tear. Slide 5. In this slide, the femur and the correlating ligaments have been removed so that you can view the meniscus in the knee. The meniscus act as the shock absorbers in the knee. The outer edge of the meniscus is rich in blood supply, but as you transition to the middle of the ligament, the blood supply diminishes. Refer to the textbook to see the different zones of blood supply for the meniscus. If the tear is to the outer third, most often it can be repaired with suturing. However, if the tear occurs in the middle or inner third, most often the torn section must be removed. Removal of the meniscus can develop into arthritic knees in the future as the shock absorber is no longer present, which means there is more bone-to-bone contact. The mechanism of injury for meniscus tears is usually a plant and turn motion, such as when the cleats of a player stick into the turf and he or she quickly turns without motion in the foot. This causes the meniscus to get pinched between the femur and the tibia. Slide 6. Notice the vast musculature of the knee. The quadriceps includes the rectus femoris and the vastus intermedius underneath it. The large muscle on the inside is the vastus medialis, and the muscle on the outside is the vastus lateralis. There are 3 muscles as part of the hamstring group. You can feel the tendons directly behind the knee. There are 2 tendons that cross in the medial side, the semitendinosus and semimembranosus, and 1 tendon that crosses on the lateral side, the biceps femoris. Sometimes athletes can strain these tendons if they experience hyperextension of the knee. This is the preferred injury rather than tearing the ACL, as muscle injuries heal much quicker. Slide 7. Review the information from the textbook regarding the bursa and nerves of the knee. Slide 8. In the next section, you will learn about the assessment procedure for the knee. Please read the information from each slide as it corresponds with the textbook. Demonstrations are also available. Audio will resume again on slide 20. Slide 20. Refer to the textbook for a thorough description of prevention for knee injuries. Audio resume again on slide 25. Slide 25. Considering the information already covered in this chapter, what ligament is prone to injury in this slide? If you said the MCL, you are correct. Sometimes valgus injuries, such as this one, are so great that they tear the MCL, ACL, and medial meniscus. This is referred to as a terrible triad. Slide 26. What ligament was injured in this picture? If you said the LCL, you are absolutely correct. A blow from the outside of the knee, creating a varus force, stretches the outside ligament. From the outline of the discoloration, it looks like this athlete was wearing a knee brace during the time of injury. Slide 27. This picture isn't very clear, but you can understand the extent of the knee injury in spite of it. The ACL and PCL are prone to tears, as shown in this picture. From the look on the athlete's face, I wonder if the pain has registered yet. Slide 28. And what about this injury? Check out the volleyball clip if you're unsure. Another combo injury is about to happen, including the MCL, ACL, and medial meniscus. Slide 29. Deep squatting and planting and turning can cause meniscus tears. Slide 30. In this section, we are going to cover the most common injuries to the knee. The first one to discuss is the MCL sprain. We've concluded that the valgus force, or getting hit on the outside of the knee, is the most common mechanism of injury. The signs and symptoms correlate with the severity of the injury. For first-degree sprains, the ligaments are only slightly stretched, but there is no tearing or laxity in the knee, only point tenderness. In second-degree sprains, there is considerable tearing or stretching of the ligaments that creates some instability, but with a definite end point in the joint. In a third-degree sprain, the entire ligament is torn, which creates major instability without a definite end point in the joint. The treatment for the coach or physical educator is to ice the knee for 20 minutes, immobilize it with a knee brace as seen in the slide, fit the athlete with crutches, and refer to an orthopedic doctor. A common question is whether the athlete has to go to the ER room immediately following the injury. Unless there is substantial pain, increased signs of shock, or obvious dislocation, it is appropriate to fit the athlete with an immobilizer and crutches and refer to an orthopedic doctor the following day. The long-term treatment depends on the severity of the injury. For first-degree sprains, the athlete will be able to return to play within a few weeks. For a grade 2 and 3 sprain, additional rehab and time is required depending upon the amount of instability. Sometimes surgery is required for grade 3 sprains. Slide 31. The second injury to discuss is the LCL sprain. The varus force, or getting hit from the inside of the knee, is the most common mechanism of injury. The signs, symptoms, and treatment correlate with the severity of the injury, as explained in the previous slide. Slide 32. ACL tears can occur with or without an outside force. In skiing, it can occur from the rotational force as the skis cross. View the clips of Byron Davis tearing his ACL, MCL, and patellar tendon. Notice there was no contact in this injury. Slide 33. In torn ACLs, the individual will feel a pop followed by immediate disability and pain. They often state that it feels like their knee is coming apart. Due to the blood supply, ACL tears produce immediate swelling. The management is RICE, fitting with a knee immobilizer and crutches, and referring the individual to an orthopedic doctor. Surgical options include using a hamstring tendon or patellar tendon in place of the ACL. Rehabilitation is extensive, but in recent times can enable the athlete to return to activity in as soon as 3 months. Slide 34. In torn PCLs, the individual will feel a pop in the back of the knee, with or without swelling. The posterior drawer test, as seen in this picture, will be positive. The management is RICE, fitting with a knee immobilizer and crutches, and referring the individual to an orthopedic doctor. Rehabilitation and surgical options depend on the amount of instability present in the knee. Slide 35. Planting and turning of the lower leg is the most common mechanism of injury for meniscus tears. This motion pinches the meniscus between the femur and the tibia. Signs and symptoms include pain in the joint line, possible swelling, and occasional locking and giving way in the knee. The athlete often experiences pain with deep squats. The challenge of meniscus tears is that the edges harden and atrophy with time, wedging themselves in the joint, causing locking, catching, or giving way. The immediate treatment is RICE, fitting with a knee immobilizer if extensive pain is present, crutches, and referral to an orthopedic doctor. Surgery depends on the extent of the symptoms, the extent of the tear, the location of the tear, and the athletic requirements. Slide 36. Fractured patellas can be caused by either direct or indirect trauma. Dislocated patellas occur during deceleration, planting of the foot, and simultaneously cutting in an opposite direction. Most patellas dislocate laterally, as seen in this picture. In fractures, there is immediate pain and swelling. Treatment for both conditions requires implementation of the emergency action plan. You must treat first-time dislocations as possible fractures. Refer to the clip to view patellar relocation. Follow-up for both conditions requires a period of immobilization and rehabilitation. Slide 37. Chondromalacia patella means softening, Malaysia, on the back side of the patella, chondral cartilage. This progressive condition often occurs because the patella does not align properly in the femoral groove, which creates repeated grinding and wearing down of the cartilage. However, the exact cause of chondromalacia is not known. Symptoms include pain going up and down stairs and a grating sensation behind the knee, especially when flexing and extending the knee. The management consists of avoiding irritating movements, icing, the use of anti-inflammatories, and the fitting of a knee brace. In addition, rehabilitation to strengthen the knee is important. If these treatments fail, then surgery is performed to remove the softened section of the chondral cartilage. Rehabilitation will be discussed in detail in the next slide. Slide 38. Patellofemoral joint dysfunction refers to the patella not sitting properly in the femoral groove. This creates a tracking problem resulting in pain and possibly creating a malacia or softening, as discussed on the previous page. As you can see in the diagram on the PowerPoint, there are numerous forces on the patella which require it to readjust as the knee flexes and extends. In patellofemoral joint dysfunction, the patella gets pulled to the outside or lateral side of the knee and creates the grind. The causes of this condition relate to several factors as listed in the textbook. However, two prominent problems associated with this condition relate to a weak vastus medialis, the VMO, which is the quad that attaches to the medial side of the patella, and also a strong or tight vastus lateralis muscle, referred to as the VL. These two muscles play tug-of-war on the patella, and oftentimes it's the outside forces that win. Accompanied in this battle is the IT band that becomes the tensor fascia lata. This tendon attaches to the outside of the knee as well and works with the VL to pull the kneecap to the lateral side. Another factor is the weak groin muscles, referred to as the hip adductors, where the VMO is attached. Ice, anti-inflammatories, and bracing can assist in the initial treatment of this condition. However, rehabilitation must be focused on strengthening the VMO, adductors, and gluteus maximus. To do this, follow this sequence. First, sit straight in your chair and contract your glutes. Your body should slightly elevate while doing this. Hold this contraction for a count of 6 and relax. Second, make a fist and place it between your legs, approximately a few inches above your knees, and squeeze your legs together, holding against it for a count of 6. And now relax. Number 3, contract your glutes and squeeze against your fist at the same time, holding for a count of 6, and then relax. And finally, contract your glutes, contract your groin by squeezing against your fist, and while you continue to hold these contractions, slowly extend one leg and contract your quads. Hold this for a count of 6, and then relax. This simple procedure develops the weak medial musculature, including the groin and VMO, and prevents or treats patellofemoral joint dysfunction. Slide 39. Osgood-Schlatter disease is repeated minor avulsions of the patellar tendon where it attaches at the tibial tubercle. The growth plate is also located in this area. This disease is often occurring in growing adolescents, and it can be quite painful. Signs and symptoms include swelling, point tenderness, and pain when kneeling, jumping, and running. Treatment includes ice, stretching, and reducing stressful activities. This condition is often considered the excuse to get out of PE. However, the student doesn't need to stop activity altogether, only to protect the knee from excessive force or bumps. In extreme cases, a complete avulsion can take place, as seen in the right X-ray on this slide. This rare condition warrants surgical intervention and extensive immobilization. In time, the pain from Osgood-Schlatter diminishes. However, the characterized bump over the tibial tubercle often remains. Slide 40. Repetitive jumping, kicking, or running creates extreme tension on the patellar tendon. The result is inflammation. The symptoms and signs transition from pain after activity to pain during and after activity to experiencing pain all the time. The complication of this condition is a complete rupture of the patellar tendon as seen in the picture. Treatment includes avoidance of repetitive movements which cause the pain, ice massage, therapeutic massage, bracing or strapping, and the use of heat and ultrasound modalities. Slide 41. Review the sections of rehabilitation in the textbook, especially noting the flexibility and strengthening exercises. Good work. This was a long chapter full of information. Please proceed to the PowerPoint for Chapter 21.